operation that removes the lamina, a posterior part of the vertebral bone in the lumbar spine, to relieve pressure on the spinal cord and nerves. It was in 1909 when Krauss and Oppenheim described the first lumbar discectomy. Erroneously, they described the herniated disc as a chordoma of the lumbar spinal canal. Mexter and Barr, considered to be the first disc surgeons, published a successful series of laminectomies and discectomies via transdural approaches in 1934. The nuances of the procedure have changed significantly since then. The spine is divided into 4 sections: cervical, which has 7 vertebrae, thoracic, which has 12 vertebrae, and lumbar, which have 5 vertebrae, the sacrum, and the coccyx. Through the superior and inferior articular processes, each vertebra interlocks with the section above and below it. An intervertebral disc sits between each vertebra and cushions the spine. The lamina and pedicle, along with the vertebral body, form the boundaries of the spinal canal, through which the spinal cord travels to convey nerve messages. There are various possible scenarios or disorders that could cause symptoms that would prompt your doctor to examine deeper and possibly propose a laminectomy. The first is radicular pain caused by spinal stenosis. Spinal stenosis is the narrowing of the articular spaces within the spine, which can impinge on nerves or the spinal cord itself. This is a degenerative condition that may eventually lead to other modifications on the spine. Radicular symptoms include pain, numbness, weakness, tingling, and other sensations that radiate from the spine to other regions of the body. A minimally invasive decompression, which means shaving bone away to provide more room around the nerve, or a laminectomy, which is removing part or all of the lamina to offer more space and relieve the impingement, may be used to treat this condition. In some circumstances, slippage of one vertebrae against the other, known as spondylolisthesis, may need spinal fusion. This can be done either openly or less invasively. The second is disc herniation. An intervertebral disc herniation can occur as a result of a traumatic occurrence. However, it is frequently caused by a degenerative process that causes a tear in the annulus of the disc, causing it to impinge on the nerves of the spinal cord itself. As the herniation progresses into a chronic condition, it produces greater narrowing, commonly known as stenosis. This in turn may cause vertebral instability, forcing them to slip against each other, the same spondylolisthesis we spoke about earlier. This movement can be excruciatingly painful, necessitating surgical fusion to stabilize the region and ease symptoms. A minimally invasive discectomy or disc removal is required for surgical repair of a disc herniation. To achieve the optimum results, this is frequently combined with decompression or laminectomy. During a laminectomy, an incision is made on the patient's lower back that varies in size depending on how many levels of the lumbar spine are being operated on. The lamina is then removed under magnification along with the ligaments that surround the posterior section of the spinal cord and nerves. By removing the lamina and ligaments, the spinal cord and nerves get additional space within the spinal canal. This operation also allows for excision of herniated disc that may be pushing on the spinal cord and nerves. Once extra space is created, the muscles, tissue, and skin are straightened and sutured shut. It is important to note that surgery does not stop the degenerative process, and symptoms may reappear within several years without adequate physiotherapy and lifestyle modification.